There's some factors that influence joint mobility, including genetics, age, sex, bony morphology. One of the bony morphologies, like I mentioned, being if you have patella alta, where the patella rides high in the knee. Another bony morphology that we want to be aware of is hip dysplasia. If a person has a really, really shallow hip socket, then it's much easier for them to dislocate or sublux their hips than someone who has a really deep hip socket. Ethnic background makes a difference, as does muscle tone, temperature, traumatic things like injury or surgery, nutrition, and hormones. And there's a lot of discussion about, even in particularly, in the dance communities, is joint hypermobility an asset or a liability? And I would say the biggest question that we need to answer is, why is the person hypermobile in the first place? Because joint hypermobility can be an asset amongst aesthetic artists, but hypermobility disorders are a liability. And there are several different patterns of joint hypermobility that we want to be aware of. There's peripheral joint hypermobility, which is limited to the hands and the feet. There's localized joint hypermobility, which is when you have just a couple of joints that are hypermobile. There's generalized joint hypermobility, which is where there's hypermobility in the large and small joints of the limbs, as well as the axial skeleton. And then there's historical joint hypermobility. That means that somebody was hypermobile in the past, but they're not anymore. Generalized joint hypermobility is more commonly associated with single gene disorders than the other types. Peripheral joint hypermobility is usually benign, but there are some exceptions. For example, peripheral joint hypermobility is more common in conditions like vascular Ehlers-Danlos Syndrome. And localized joint hypermobility, as I mentioned, is of all of those types, more often acquired from trauma or training, etc. And I don't know how many people will have seen the Beighton score, but this is the most commonly used scoring system to assess for generalized joint hypermobility. And it looks at a number of different maneuvers. So one of the maneuvers is, can you touch your thumb to your forearm? Another maneuver is, can you bend your fifth finger back more than 90 degrees? And by the way, you score 1 point for each of these maneuvers that you can do, and the right and the left each get a point. So far, I've identified 4 points. Then the other points are relative to elbow hyperextension. Does the elbow hyperextend by more than 10 degrees? And again, very important to use a goniometer for this, because this is 10 degrees right here. So that's pretty subtle, whether it's 10 or 12 or 8, pretty subtle. So you really want to be measuring with an orthopedic goniometer in order to get the most accurate measurements when we're looking at knee and elbow hyperextension. So those are 4 of the points: right elbow, right knee, left knee. And then the last point, or the 9th point, is, can the person put their palms on the floor without bending their knees and their feet together? There are other scoring systems as well, as listed here, and we don't have time to go into all of them, but I just wanted you to see that there are lots of scoring systems for generalized joint hypermobility. And the important thing to remember is that these are not EDS scoring systems, and I'm sure many of you know what EDS is. For those that don't, we'll be talking about that very shortly. But just remember that these scoring systems are for generalized joint hypermobility. They are not specifically for if you score positive on these scoring systems, that does not mean that you have EDS. Okay, so there's advantages and disadvantages of the Beighton scoring system. It is very easy and fast to do. It's very easy to learn, and it has been validated in many, many studies. It does, however, look at only a small number of joints, and it's biased towards the upper extremities. So you'll notice that between the thumbs, the finger, and the elbows, that's 6. When you count right and left, that's 6 of our 9 total points. And so there's a lot of bias there towards the upper extremities. It also only assesses all of these joints in one plane of motion. And we have lots of joints that go in multiple planes of motion. And it also excludes joints that are commonly injured, especially in certain populations. For example, in dancers, the ankle, the knee, and the low back are most commonly injured, and also the hip. And so it's important to consider some of these other scoring systems in some of the other populations. Also, joint range of motion is continuous. And this tool, the Beighton scoring system, looks at it as actually something that is more dichotomous. So it's either a 0 or a 1 that you score for each item. So the Beighton score is something that can be very helpful, but we should not be using this alone to exclude generalized joint hypermobility. We still should be using our judgment as clinicians in order to differentiate between the different types of joint hypermobility and generalized joint hypermobility. One of my favorite scoring systems is called the 5-point questionnaire. And the questions on that, the first two you can see directly come from the Beighton score. Can you now or could you ever place your hands flat on the floor without bending your knees? The next question, can you now or could you ever bend your thumb to touch your forearm? A lot of people might know the answer to that first one from the historical standpoint, but a lot of people don't know if they could touch their thumb to their forearm back when they were younger, if they never really tried doing that particular maneuver. So these are really helpful questions, but it's good that they included some other things like, as a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? And also asking about dislocations, and you consider yourself double jointed. If you answer yes to 2 or more of these questions, there is a very high chance that you have generalized joint hypermobility. So next, let's talk about why joint hypermobility and joint instability matter. I have 3 primary reasons why joint hypermobility matters. Number 1, joint hypermobility in and of itself is actually very common. It may contribute to pain and other symptoms. And it also has the potential for physical and psychological sequelae that can be avoided if we recognize and treat these conditions sooner. Symptomatic joint hypermobility means that a person has joint hypermobility in combination with pain, recurrent subluxations, and other musculoskeletal overload injuries. These people may also have decreased functional capacity, lower strength, suboptimal muscle activation, and quality of force control. And we know that there's been a lot more attention over the past decade, but we're still exploring the determinants that cause joint hypermobility to become symptomatic. Well, what are the Ehlers-Danlos Syndromes? These are hereditary disorders of connective tissue. And in 2017, we were introduced to a new classification that identified 13 different subtypes that were based out of mutations in 19 different genes. The hypermobile type of EDS is by far the most common. Some people have said 80 to 90% of cases of the Ehlers-Danlos syndromes are the hypermobile type. However, other people are saying it's 90% plus. We don't know the genetic marker for hypermobile EDS, so this, of course, makes these kinds of determinations much more challenging. All of the other subtypes, all of the other variants, we know the genetic markers for these. We just don't know the genetic marker for the most common type, the most common subtype, the hypermobile type. The next most common subtypes are the vascular and classical subtypes, and all of the other subtypes are extremely rare. And I published a paper recently looking at the different types of joint hypermobility. So you can see on the far left, even though this is not in terms of severity, by the way, we talked about peripheral joint hypermobility, localized. We talked about generalized joint hypermobility, and I just mentioned the Ehlers-Danlos syndromes. And in between here, we have something called hypermobility spectrum disorders. And I want to point out that this is not a severity scale. We really toyed with how to present this information in a way that it didn't come across as a severity scale. We had a lot of different ideas about how to present this information, but it's always challenging to come up with these types of figures. Hypermobility spectrum disorder, we use that diagnosis if somebody presents with symptomatic joint hypermobility. So a person has symptoms that we think are attributable to their joint hypermobility, and they don't meet the criteria for either one of the Ehlers-Danlos syndromes or some other condition that might explain their symptoms. So this is kind of like the IBS in the joint hypermobility world, that if we don't have another explanation, then we call it hypermobility spectrum disorders. It's a diagnosis of exclusion, basically. And this is the specific diagnostic criteria for hypermobile EDS that was developed in 2017 by the International Consortium on EDS and HSD. And you can see that it does start with the Beighton score. And then you can gain an additional point if you score 2 or more on the 5-point questionnaire. And then it goes into some very, very specific findings. This was designed by expert clinicians, not based on data that we had necessarily. So they are definitely revising these criteria right now. It's very challenging because we're trying to identify the gene for hypermobile EDS. So we need to come up with some better criteria to decide, what is this condition specifically? But at the same time, we're lacking data because we don't know what the gene is. So it's kind of a chicken and egg type challenging situation. And in this paper, they found a diagnosed point prevalence of EDS, or at that time, the term that was used was JHS. And they found that basically 1 in 500 people had one of these two conditions. So this would basically be saying that nowadays, either between the Ehlers-Danlos Syndromes and the Hypermobility Spectrum Disorders, that we would anticipate about 1 in 500 people having one of these conditions. They also found that people with EDS or joint hypermobility syndrome were associated with higher odds of having other diagnoses and drug prescriptions, and significantly more diagnoses in other disease categories and prescriptions in other disease categories. The delay to diagnosis is really, really significant. So this is an important thing to be considering. The latency to diagnosis can be very, very long. So in some people, they're diagnosed within 5 years, but then you can see that there's people out here who it's taking 30 to 35 years, 35 to 40 years. So it's really important to be having more awareness of these conditions so that we can get people assessed sooner, we can get them diagnosed accurately, and we can start them on a treatment plan that will hopefully help mitigate their symptoms. Interestingly enough, in this same study, they found that before puberty, males and females were diagnosed with about the same frequency, but then once puberty happened, females were diagnosed much more than males. And we believe this is probably true for a variety of reasons. One is the impacts of hormones. We know that the female hormones like estrogen tend to contribute more to some of the symptoms that people experience, and the cycling of hormones can also contribute to people's symptoms. So sometimes what we will do actually is we will stop a young woman's menstrual cycles, we'll just suppress them completely in order to avoid those periods where they would have extreme laxity in the days leading up to the onset of menses. And I really like this diagram because they talk about the asymptomatic joint hypermobility on the left and then the symptomatic joint hypermobility on the right. So the tip of the iceberg in both cases is joint hypermobility. That's the part that we can see. But really, even though that's the part that's more obvious and easier to assess, really joint instability is probably more important and probably the bigger problem. So if we look at the people on the left, most people will remain asymptomatic. These people on top, although some people will develop symptoms, and then they'll be more related to this iceberg on the right. If a person with joint hypermobility develops orthopedic deformities and skin alterations or other signs of tissue fragility, then we want to rule out a heritable disorder of connective tissue. And that's on the right part of the iceberg. And above the waterline, again, this is the joint hypermobility that tends to stand out in the clinical evaluation. But below the waterline, these are the symptoms and signs that require further evaluation. Here in the upper left, we have the musculoskeletal symptoms that can occur: pain, recurrent subluxations, and overuse injuries. In the lower left, we have multisystemic symptoms that are quite common. For example, fatigue, orthostatic intolerance. That's when you have upright posture, you tend to get dizzy, palpitations, nausea. You might have heat and cold intolerance, etc. And also symptoms can occur in the gastrointestinal and genitourinary tract. And in the upper right, we have orthopedic deformities like scoliosis or pectus deformities. That's when we have deformities of the sternum. And we can also have things like hip dysplasia, club feet, etc. And in the lower right here, we have tissue fragility, bone problems, and vascular. And then here we have things that we can see in the skin, like abnormal stretch marks, soft velvety skin, skin that's super stretchy, delayed wound healing, or something called atrophic scarring. So, what are some other symptoms, or what are the symptoms that we want to be thinking about that can be related to joint hypermobility and joint instability? Pain is a very, very common finding in people who have symptomatic joint hypermobility. And it can be from a whole variety of causes. It can be due to joint subluxations. It can be due to something called CRPS, which is complex regional pain syndrome. If a person has a joint immobilized or has surgery on, usually it's more if you have something in your hands and your feet, you can develop complex regional pain syndrome. It's very, very painful. It's excruciatingly painful, and you get swelling, color change, a lot of problems related to that part of the body, and then it can actually spread to other parts of the body as well. So this can greatly impact someone's quality of life, and we also get things like nerve compression. And what are the most commonly affected joints in the Ehlers-Danlos syndromes? Well, we know that the shoulder is very commonly affected. We also see the knee, etc. So we know that these joints, they kind of give a breakdown here of what the different joints are and how they are impacted. And we also want to be thinking about like the sacroiliac joint, for example. Most people think the sacroiliac joint really doesn't move, and it doesn't move much, but it still can cause problems in people that have symptomatic joint hypermobility. And the mean number of joints affected in this study was 5.4. We also want to think about other sites of pain, like headache, abdominal pain, and visceral pain. This is a diagram from a paper where they showed multiple different parts of the body and how they can be impacted. So whether we're looking at the eyes, craniofacial, the lung, I've already mentioned some of these symptoms that people can experience, the chest, like the chest wall deformities that we talked about, cardiac things like mitral valve prolapse, aortic root dilatation or dissection, aortic aneurysm, etc. The spine, we can see scoliosis or kyphoscoliosis. In the gastrointestinal and genitourinary tract, we can see perforations, we can see slow motility, something called gastroparesis, we can see rupture, diverticulitis, we can see rectal prolapse, for example, and things like constipation are extremely common because of laxity of the intestines. And so we get some dilatation, and it's a lot harder for things to move through the digestive tract. In the musculoskeletal system, we can see joint contractures, joint hypermobility. We can see osteopenia or osteoporosis where the bone density is low, and we can see congenital hip dislocation. We also in the muscles see exercise intolerance, muscle weakness, and or myopathy. And we also see things in the feet like flexible flat feet and hammer toes. And I mentioned a lot of the things that we see in the skin already, but I just want to mention also we see things like hernias, and we see these widened atrophic scars. So where the scar didn't heal in a nice thin line, but it actually healed in a little bit more wide, and it's wide side to side, but then it's thin top to bottom. And the presentation amongst different types of EDS is quite variable, even amongst patients that have the same type. And it can even be amongst family members that have the same type. And we can encompass dysfunction of virtually any tissue or organ. This most commonly impacts, as we mentioned, the skin, musculoskeletal, cardiovascular, respiratory, GI, GU, craniofacial, and ophthalmologic systems. And this was another study looking at the different symptoms that people were experiencing. And a lot of people have been really trying to figure out how to best diagnose hypermobile EDS and HSD because of the fact that these are clinical diagnoses. For the other types, of course, we need to be able to recognize some of the core features, but because we can send the person for genetic testing, the clinical features are a little less important. Some of the fascinating things that we see on this list, high myopia, I didn't mention that before, but also hyperacusis. So a lot of people that have EDS are extremely sensitive to sounds. And in this study, they looked at extra musculoskeletal manifestations in the Ehlers-Danlos syndromes, and they found a lot of autonomic dysfunction, migraine, and fibromyalgia, and cardiac problems, and mast cell problems. But we don't know if these are comorbidities of the Ehlers-Danlos syndromes or non-musculoskeletal manifestations. The comorbidities of Ehlers-Danlos syndromes that are most common are dysautonomia, which is where the autonomic nervous system doesn't function properly. And this can cause problems, as I mentioned, when we go from sitting to standing. And the two most common types of dysautonomia are neurocardiogenic syncope. So that's where people lose consciousness. And then POTS, postural orthostatic tachycardia syndrome. With postural orthostatic tachycardia syndrome, when a person goes from lying down to sitting or from sitting to standing, they don't tolerate that upright posture. So as I mentioned earlier, they'll get dizzy, they feel palpitations, brain fog, heat and cold intolerance, etc. And the other common comorbidity with these conditions is mast cell activation syndrome. This is where the mast cells, which are part of the immune system, become more easily activated, degranulate, and release their chemicals. And then these chemicals can travel all throughout the body, and they cause all kinds of symptoms. So some of the common things that we might see might be things like rashes, hives, flushing, itching. We might see gastrointestinal symptoms like abdominal pain, diarrhea, gastroesophageal reflux. We see things like headache. These mast cell activation syndrome symptoms, like EDS, can occur in just about every system of the body, And there's a fascinating article by Dr. Lawrence Afrin called the title is Some Cases of Hypermobile Ehlers-Danlos Syndrome May Be Rooted in Mast Cell Activation Syndrome. Because when the mast cells are activated, they release these chemicals, some of which are proteases. And proteases actually degrade connective tissue and can make the connective tissue more weak and can make hypermobility either worse or can, in some cases, likely cause this to happen. One of the most common symptoms that we see in these conditions is fatigue, and this can be related to a variety of factors. It could be secondary to poor sleep, poor nutrition, suboptimal hydration, especially if somebody has dysautonomia. They need even more hydration than the average person. It can be due to inadequate recovery time. People can get fatigued because they're in pain and they're having so much difficulty. The pain causes insomnia, and then the insomnia makes the pain worse. And a lot of these things happen in these really vicious cycles that can be really hard to break. Anxiety can also be another contributing factor to fatigue, as can medications and mast cell activation syndrome. And the challenging thing is that hypermobile EDS, or hypermobile Ehlers-Danlos syndrome, and POTS, or postural orthostatic tachycardia syndrome, and mast cell activation syndrome cause a lot of overlapping symptoms. For example, weakness, fatigue, abdominal pain, diarrhea. And so it can be very challenging to figure out which condition or conditions this person might be experiencing, because we know that there's some things that are more specific to hypermobile EDS, some things that are more specific to POTS, and some things that are more specific to mast cell activation syndrome. But then there are these other things that are common in all of them. But there's one particular thing that the authors, I believe, forgot to include in their diagram, and that's anxiety. We know that anxiety is an extremely common finding in people who have hypermobile EDS, and there's a whole lot of reasons why this might be the case. There's actually been some imaging studies that have looked at the amygdala, which is the fear center of the brain, and have found changes in the amygdala in people that have hypermobile EDS, or that are more hypermobile than people who have no hypermobility at all. And anxiety can also come from dysautonomia. So if your autonomic nervous system is dysfunctional, or if your sympathetic nervous system is hyperactive, then that will cause your heart rate to go up. You will release the fight, flight, or freeze hormones in your body, which will make you feel very, very anxious. So anxiety can come from a physiologic source, or it can come from more of a psychologic source. So we know that the presentation of these conditions are very, very heterogeneous and can occur, as I mentioned, in just about any bodily system. So I could have a patient who looks more like this on the left, where they have a lot of musculoskeletal problems, but maybe not as much in some of these other bodily systems. Or if the person could maybe be a little bit more balanced throughout the different systems. So oftentimes I will have people fill out questionnaires so I can get a sense of where are they struggling the most. So the approach that I use when I'm working with someone one-on-one is I developed an acronym for it called MENS PMMS. So once I've completed my evaluation and established a working diagnosis or diagnoses, this is part of my treatment approach. So I first start up here with movement and then go on to education, nutritional biochemistry, sleep, psychosocial, medication, modalities, and supplements. And I did discuss this recently in a journal article, that same one that I mentioned earlier, and also in a talk that I'm doing for the Ehlers-Danlos Society conference, global learning conference that they're having in Dublin, which is the beginning of August. So if someone is interested in getting more information about my approach, as well as a whole range of talks, there's an incredible lineup of talks for this conference, and there are affordable options both for virtual. In person is of course more expensive, but the virtual options are probably pretty reasonable. So when should I suspect a hypermobility disorder? Because proper diagnosis is really, really essential. And then, of course, we want to identify what's going on with that particular person in the different bodily systems. So anytime a person comes to me and they're experiencing persistent pain, if they're experiencing things from microtrauma, like problems with ligaments, tendons, maybe they're experiencing a lot of tendinopathies, they're describing a lot of joint dislocations or subluxations. If they're describing things that make me think that they're experiencing something called hyperalgesia or allodynia, and what these are when the nervous system doesn't process pain signals properly, we can get hyperalgesia and allodynia. Allodynia is when something that is normally not painful is painful. Like, for example, the sheets touching your feet. Some people have pain from sheets touching their feet or clothing touching their body. Hyperalgesia, on the other hand, is when something that is normally slightly painful is more painful. And so I'm just going to go through a few of the letters of the acronym really quickly. The first letter, M, stands for movement. This can be a variety of different ways, but I want to get people moving more and moving better. And first moving better and then moving more, by the way, because we want to have a correction of dysfunctional patterns. We want to work on posture, sleeping posture, sitting posture, standing posture, because we want to maximize joint stability and focus on neural retraining. So proprioception is knowing where the body is in space without looking. And by improving proprioception, which is often impaired in people that have joint hypermobility, if we can work on proprioception, we can decrease these joint subluxations and dislocations and improve joint stability and improve the function of the neuromuscular system. We can do this via physical therapy, occupational therapy. I often recommend that people do water therapy. Some of the advantages of working in the water include the contact of the water with the skin is very helpful for proprioception. The buoyancy of the water offloads the joints. Of course, we don't have gravity. And then the resistance of the water makes it easier to use your muscles without putting as much strain on your joints. Education is very, very important. Once people understand the different diagnoses and how pain processing works, I think it makes it easier to do the what. If you go to the doctor and you have a typical 5 or 7 minute visit, they don't really have the time to explain to you why it's so important to address your sleep, why it's so important to address things like nutrition. And so that's not very empowering. They just tell you what to do. Do this, do this. And it's really hard to be motivated sometimes to do those things. But I take the time my visits are a lot longer. I take the time to educate people about why these things are so important so that they will feel more empowered and be more likely to actually be able to carry out the recommendations. Nutritional biochemistry is so important. There's no one size fits all, but there are some general concepts that we can consider. For example, I want to think about how well does the gut function? And do we need to assess this via some lab tests? Some people have been sick for so long and have had so many problems that their gut is really not working very well. We want to be thinking about whole foods and minimizing things like sugar, gluten, dairy, red meat, and artificial sweeteners. Now, those are things that work in some people. The sugar and artificial sweeteners, I would say, are things that are true for everyone. I would like for everyone to minimize their sugar and artificial sweeteners, especially in people with the Ehlers-Danlos syndromes, tend to be very problematic. We want to be thinking about things like prebiotic and probiotic foods and decreasing soda, sports drinks. And when I say sports drinks, I don't mean the like electrolyte drinks. Those actually do have a place. Things like Liquid IV or LMNT, those types of products I think are very helpful. I don't like the sports drinks that have caffeine because caffeine actually dehydrates the body and can cause more tachycardia. So that can be problematic. Juice is not helpful because it tends to be a very concentrated source of sugar. I would rather that people eat whole fruits than drink juice. We want to think about sleep. Is the person awakening feeling refreshed, or are they exhausted during the day? We want to optimize sleep hygiene. For example, taking electronic devices out of the bedroom and minimizing the use of screens before bed. We want to address circadian rhythm abnormalities. I've had patients who they're going to bed at 4, 5, 6 a.m., and that's really problematic. Even if you're going to bed at midnight or 1 a.m., that's not optimal. I like my patients to be going to bed around 9 or 10 and falling asleep ideally within 15 to 30 minutes. And so when I'm working one-on-one with somebody, we address what's going on. Why aren't you falling asleep? Why aren't you staying asleep? Why are you awakening too early? We dig into what particularly is going on with that person's sleep, and also addressing things like depression, anxiety, and or if they're having problems with dysautonomia. Because if your heart rate is spiking during the night, that can also cause you to awaken. It's very important to address and treat the mood and cognitive problems that can co-occur with these conditions. So if a person has anxiety, depression, something called catastrophization, this is very, very important. So catastrophization is where we think the worst is going to happen. Oh my gosh, this is just the worst ever, and the worst thing is going to happen. When I first learned about catastrophization, this was so empowering for me because I realized if I can change my beliefs, if I can change what I think is going to happen, then maybe I can actually change how I feel. And it really did help a lot. Of course, this is in combination with a whole bunch of other things, but I do believe that catastrophization is an important thing to address when it's present. Kinesiophobia is the fear of movement. A lot of people do develop fear of movement because if we have symptomatic joint hypermobility, we often injure ourselves doing very, very simple things, getting up off the sofa, reaching into the back seat to grab the purse, things like this that other people can do without any problem whatsoever. We reach up to grab something out of a cabinet and dislocate or sublux our shoulder. So it's very important to address, though, that fear of movement and try to move in the right way. I really encourage people to think about their green, yellow, and red zones. Your green zone of movement, or your movements that you know are generally safe. The red zones are things that you know you're generally going to be paying for. So if you overdo it, those are your red zone things. You're going to be, experiencing, you're going to be experiencing effects for days, if not weeks. So we want to stay out of the red zone. We want to stay in the green or tipping a little bit into the yellow zone, because ideally I want people's green zone to increase. And so depending on where they're at, I try to work with that as well. We want to identify and manage non-supportive home and work situations, and counseling can be extremely beneficial. And what I tell my patients is you deserve to have a counselor on your team. There's a lot of different modalities that can be helpful, including laser, light therapy, massage, myofascial release, acupuncture, acupressure, vagal nerve stimulators, and ultrasound. I really encourage people to try these different things in combination with other things, and we want to have expectations that are realistic. I think a big mistake that a lot of people make is they're looking for that one thing to fix their problems. I know when my pain was really out of control and absolutely horrible, that's what I was doing. I kept looking for the next thing, and I kept expecting it to be the thing that was going to take my pain away. But instead, if we focus on function and improving function, and we also focus on the 10% rule, if we get 10% improvement from taking this supplement, if we get 10% improvement from working with this therapist, if we get 10% improvement from doing this type of light therapy, another 10% from this medication, all of that is going to add up to 40% improvement. And that's actually meaningful. So the whole goal is to reduce this cycle that can cause the pain to get worse and worse and worse. And there's a lot of different areas that we can intervene. So what can you specifically do? So a few recommendations that are specific to these conditions. Number one, stop doing party tricks. A lot of my patients and clients will do various different tricks with their hands, with their body. They'll show these off at parties. And I used to do this all the time. I would pop my hip in and out, which I know now is probably snapping hip syndrome. I would put my feet between my legs. I would do all kinds of things with my hands. And instead, I would encourage you to do these one final time, have somebody take photos and videos. And that way, when you go to the doctor and if they're asking you these questions, you can say, I don't do those anymore, but let me show you a picture of what I used to do. We want to work on improving our proprioception and our balance because we obviously want to avoid falls, especially since we really often have low bone density. You don't want to sink into end range postures. So you don't want to be standing, sinking into knee hyperextension, for example. We want to prioritize neuromuscular control and stabilization to reduce joint instability. And we want to really be focusing on our movements and focusing on nervous system safety. Some people say, oh, no, people with joint hypermobility should never, ever stretch. As somebody with joint hypermobility who went through a pretty long period without stretching at all, I now have parts of my body that are incredibly rigid and immobile. And so I really wish that I didn't go through that long period of not stretching. So I would encourage people to stretch very intentionally, very thoughtfully, and ideally working with a physical therapist or other skilled professional. We want to be extremely careful with procedures and surgery because they don't always address the underlying problem. And we want to make sure to address the underlying problem in order to get the most optimal results. Other things that we can do that are not as specific to these conditions are, choosing our instructors really, really carefully. If you're taking gymnastics, doing dance, doing, any type of exercise program. If you're a musician, for example, you want to make sure that you're working with instructors who are really able to adapt their techniques to what you specifically need. You want to listen to your body with curiosity and ideally not anxiety. Back when my pain was horribly out of control, I had so much anxiety and I would get more and more anxious as I was in more and more pain. And that's definitely not helpful. Instead, if you can say, this is really interesting. My body is giving me information. My body is telling me that food didn't particularly agree with me, at least not on this particular day. And then incorporate that information and use that data to make your choices in the future. And our bodies change over time. So some things that you don't tolerate at one point in time might not be the same things as what you don't tolerate at other points in time. You want to learn to advocate for yourself and for others. And I really encourage people, and I work with people one-on-one, both as clients and as patients, and I'll explain in a minute what the difference is, to work on their one sheet and also a 3 to 5 sheet. So the one sheet is a bullet point list, very, very succinct, that has your basic medical history. Now, you're going to need to update this quite frequently because it has the absolute bare minimum facts. The 3 to 5 sheet is more expanded and includes a little bit more information, but it's still super succinct and a bullet point list. So that way you can make an extra copy, take it to your doctor's appointments, etc. We want to make it easier for your doctors, your therapists, whoever it is that you're going to capture the low-hanging fruit. Well, what else can you do? You want to find credible resources. Look at the initials after a person's name. That's much more telling than anything else. So after their name, are they an MD or a DO? So they had traditional medical training. Are they an RDN? If they're an RDN, a registered dietitian nutritionist, that means that they had to meet the qualifications for that particular degree. So you want to make sure that you look at the initials after a person's name in order to best know what type of training they had and are they most going to be able to help you. I have a free podcast called Bendy Bodies with the Hypermobility MD that I would encourage you to listen to. And also, you want to utilize support groups very, very wisely. In terms of my one-on-one services, I do see patients through Bendy Bodies, and I can see somebody from anywhere in the world that way. I cannot treat you as a patient, though, if I haven't seen you one-on-one in person in Colorado or Wisconsin. And so in that case, what I do is I give basically like a one-on-one. So it's like a one-on-one talk, but I get a lot of information from you. And then I give you general information. I put in your notes, people who have blank often benefit from blank. And that way you can take it back to your own healthcare team and or incorporate these things yourself in order to improve your functional capacity and quality of life. A lot of the things that I recommend are things that you don't need a doctor for. So a lot of people have found that to be very, very helpful. I kind of consider myself like a combination of a detective and a translator in that regard. So in summary, I definitely wanted to give you this article that you can check out online. It is unfortunately no longer available free, but I believe that you can purchase just that single article, and there's a part 1 and a part 2. Further investigation is warranted anytime an athlete or non-athlete presents with symptoms or signs in multiple different bodily systems. And there's a saying that was first said by Dr. Heidi Collins, I believe, if you can't connect the issues, think connective tissues. And a patient said to me once, these are owner-specific diagnoses. And I thought, oh, this is a really good way to put it, because it does present, these conditions present very, very differently in the different people that have them. Take-home points that I want you to remember. Hypermobility is frequently missed as a contributing factor for pain and other symptoms. Many people experience a lack of validation and belief from healthcare professionals, friends, and family, and experiencing pain and other unresolved symptoms, plus medical uncertainty, can be very traumatizing and further increase pain and other symptoms. But there are things that you can do to improve your quality of life and functional capacity. And I want to say thank you so much to Neil Asher Training Global Campus for having me on for this webinar today. And you can get more information. I have lots and lots of resources on my website at www.hypermobilitymd.com. I have tons of different things that you can check out there. You can also follow my Bendy Bodies podcast and YouTube channel. Also go to bendybodiespodcast.com. Here's where you can email me, info@bendybodies.org. And I am active on a number of different social media channels. I would love to connect with you over there at Hypermobility MD. And I'm on Instagram at bendy_bodies.
If you liked this video and you want to see more, make sure to subscribe below and don't forget to hit the notification button.